Hi there and welcome back. My name is John. I've been a type 1 diabetes patient for the past 45 years. I am also an emergency medicine physician in New Hampshire, and I spent about 15 years running a diabetes center in northern New York. During that time, I got to work with numerous pharmaceutical companies, insulin pump and device companies, and a lot of patients in various stages of various types of diabetes. During my emergency medicine career, I spent a lot of time dealing with people suffering from complications of diabetes and some of the nasty side effects that our medications can give us. In June, I started this video series to enhance awareness. I thought if we shared stories, successes, failures, hints, and ideas, we all might progress at a better rate and a much more successful rate. I've talked about my diagnosis. I've talked about going through grade school and high school. I even interviewed my own mother here to provide a different perspective, one that I think must be very frightening. So ideally, you get to watch these series. Ideally, you throw a comment about what you liked, didn't like, what you'd like to see in the future, or even some of your own ideas so that we can all do a much better job at living with this disease. As you know from previous videos, I don't consider diabetes a disease. I consider it a lifestyle. It demands respect, but you're in control. So today, I thought we'd go on the dark side. Today, we're going to talk about one of the complications of diabetes. The reason I decided to do this was an incident that I went through at work. About a week ago, one of my smart-ass nurses that I work with decided that he would try to have some fun at my expense. With 4 or 5 other nurses in the room, he made the comment, "Are you going to start an OnlyFans page to show your feet now before they get all necrotic and disgusting?" The room stayed fairly silent. I was a little bit shocked at the crudeness and unbelievable inappropriateness, but I kept my cool and moved on with life. Then I got to thinking about it and figured, you know what? Maybe he's just trying to show me the way to go. Maybe this is God speaking through this twerp, telling me this is the way your videos need to go. Hit some of the dark side, some of the reality of diabetes. So here we are. Today we're going to talk about diabetic neuropathy. This is probably one of the scariest diabetes complications. People are always afraid, and I always had questions from patients about nerve damage and the fear of losing a foot or a toe or all the way up to the ankle and having to deal with all of that pain and disability. So it's definitely up there in the top complications that we all want to avoid. For me, I think blindness is probably number one, but I certainly would want to touch this one. So today we'll look at what is neuropathy, what are the types, what's a little bit of the physiology. We'll go over some of the symptoms. We'll talk about amputation, the end-all be-all for it. We'll talk about some of the other treatments to help avoid amputation. We'll talk about some of the advances made in treatment of neuropathy, and most importantly, we'll talk about preventing neuropathy. Ideally, between the stories you may share and between what I provide here, at least one of us, if not all of us, can avoid this horrible complication. So let's get started on our road to success. What is neuropathy? Anytime you hear the term neuro in the body, it has to do with the nervous system or nerve cells. Neuropathy is a breakdown or damaging of nerve cells due to high glucose levels. So let's take that statement. Breakdown of nerve cells due to high glucose levels. What is a nerve cell? Nerve cells, the easiest way to think of them, a lot easier 20 years ago when we didn't have cell phones, but it's a telephone line. These are telephone lines coming from your brain all over your body, enabling you to walk, talk, blink, speak, pee, jump, feel, everything. This is all run through nerve cells, through telephone lines. What do we mean by high glucose? Well, you and I measure our glucose by blood sugar testing or a sensor if you have one. Sometimes our providers are forward thinking enough that they're downloading the sensor data to get a good look at what's going on. Sometimes they use the hemoglobin A1C, and if you remember from prior discussions, the hemoglobin A1C is a 3-month average of your blood glucose levels. So when those levels are staying up higher than they should be for long periods of time, we risk damage to these telephone lines. So there's 2 main types of telephone lines that we're going to worry about: the autonomic nervous system and the peripheral. So with autonomic neuropathy, we're dealing with anything that happens automatically in the body. This would include blinking, breathing, your heartbeat. your digestion. Those are the big ones. And these cells, these telephone lines, can certainly be damaged by prolonged high blood glucose. So let's take a couple of them. Cardiogenic neuropathy. Again, you hear the term cardio in the body, you know as well as I do, it means heart. So with cardiogenic neuropathy, the telephone lines that go to the heart that help it increase rate, that help it work harder to maintain blood pressure, get damaged due to prolonged high glucose levels. As a result, patients with cardiogenic neuropathy can have a resting tachycardia, which means a resting very fast heart rate. They can have early fatigue. They can have problems with blood pressure, all kinds of issues that really prevent them getting more exercise. When we think of diabetes, and we think back to our talks on both type 1 and type 2, exercise helps your insulin work better. It helps the glucose get into the cells. It lowers the blood glucose level. So now you have a complication that makes this very difficult, if not impossible to do. So you're more sedentary, watching TV on the couch, probably snacking inappropriately, gaining weight, adding layers and layers of insulin resistance, and making your diabetes complications more powerful, more difficult to control, and more frequent. So you can see how we get into this vicious cycle with it. Moving down the line from the heart in the autonomic nervous system, we're going to look at the stomach. This is called gastroparesis. Gastro, again, is a medical term referring specifically to the stomach. Paresis meaning not moving. So what happens with gastroparesis is the nerves that go to the stomach and part of the small intestine are damaged by high glucose levels. This in turn slows down and disrupts how food is moved through the digestive tract. So a couple of impacts on our life here. We see a similar effect with the GLP-1 agonist medications that I talked about a few weeks ago. They slow down food moving through the stomach. This makes the person feel full earlier. It also helps them eat a smaller amount of food. It can also cause side effects like vomiting and nausea. So as you can imagine with gastroparesis, unfortunately it's not predictable like taking that injection of Ozempic or Trulicity. It happens typically all of the time, but it can have varying intensities. It also depends on what you're eating, how much you're eating, and time of day. So the patient may have to eat very small meals for most of the day. They may be able to eat a normal meal, but a fattier meal is going to take longer to digest, and they have a hard time with it. Add to that this occasional nausea and vomiting they might go through. Now the glucose is being absorbed at a different rate. Well, we're trying to time our insulin dosing with our glucose, our fast-acting insulin with the glucose. Now it's much more difficult to do. Now, if that patient has a sensor, it's going to be a little bit easier, but it's still very difficult to control something that's already difficult to control. So we used to think about diabetes as juggling. You're balancing your exercise and your diet and your insulin. Now we've thrown a whole bunch of more flaming bowling pins into that juggling act and made it much more difficult for the patient. Continuing our work southward with the autonomic nervous system, we have the bladder. This condition is called neurogenic bladder. And what this means is that the nerves, the neurons is the official term for the nerves, or the telephone lines, if you will, that work on the bladder's sensation and the bladder's contraction to empty get damaged. So these folks have a lot of issues. Number one, they have a very difficult time knowing when they really have to pee. So this can result in emergent runs to the bathroom, can result in accidents and embarrassment, hygiene issues. Add to that, when they do go pee, their ability to empty the bladder isn't great. So they maybe empty half of it, and that urine sits there. So your risk of a urinary tract infection goes up. Now, for us younger folks, a urinary tract infection might not be a big idea, but when you get older, and I see this all the time in the emergency department, the urinary tract infection can cause a lot of issues and even death for elderly. A lot of times they don't realize they have it. So now let's take the symptoms of a urinary tract infection. Urinary frequency. It hurts when I pee. I have to go right away. There's no waiting. But when I go, there's only a little bit there. Now, with a neurogenic bladder, The frequency, the fact that I have to go more often, I'll never notice that because I don't notice when I have to go. The pain when I pee, I'm unlikely to notice that because a lot of the nerve cells are damaged. The hesitancy and the urgency are also going to be limited. So I may not even know I have a urinary tract infection until it rises to the kidneys. Now I have a kidney infection or a pyelonephritis. Now I have a fever and I'm vomiting. We know vomiting with diabetes can be real detrimental. Or worse yet, it gets into the blood. Now I'm what we call septic. My blood pressure is low. My body's working hard to fight an infection that has gone systemic. I end up in the ER and I can die from this. So you can see how some of these complications can have these real nasty cyclical effects that can hurt a lot of us. So we definitely want to avoid neuropathy, and we certainly want to avoid autonomic neuropathy. So let's flip the page and look at the other side of the neuropathic world. This is peripheral neuropathy. So peripheral in the medical sense is on the outside, the periphery. These are our fingers and toes. These are the folks that get numb feet, painful feet, ulcers on their feet, and have all kinds of issues. It can happen in the hands. It's more frequent in the toes. And essentially what's going on there, to step into a little bit of the physiology of neuropathy, is you have this long, thin nerve cell going down to the toes or going to the bladder or the heart or the stomach. And it is dependent on glucose balance to maintain homeostasis, energy levels, activity levels, and do its job. So with prolonged high blood glucose, what we get is a lot of free radicals. And this is a term you may have heard off and on, and we certainly deal with it a lot in diabetes. There's free radicals and there's the antioxidants. Again, this has become a big marketing thing for food. And don't worry, I have a video coming up about the food industry, which will scare you. It should scare you. Anyway, the free radicals in the body are matched up with the antioxidants. As long as those levels are in favor of the antioxidants, we're fine. So when the free radicals start getting above it, these are molecules that have an extra electron and they're very unstable, and they can cause a lot of cellular, protein, and DNA damage. And that's how they hurt the blood cells. Naturally, or as you may have guessed, when the blood sugars are high for a prolonged period of time, we have excess of free radicals. It overtakes our antioxidant ability, and cells and damages start to occur. That's one way that the neuron or the nerve cells are damaged. The other way is an indirect effect from the diabetes, is the small blood vessels that feed these nerve cells. These are tiny little capillaries, especially think about your pinky toe. Tiny little blood vessels giving you color there, blood flow, giving you nerve cells that are functional for movement, for sensation, keeping your toe warm. Well, these start to get damaged from the high blood glucose as well. So as these cells get damaged, their ability to bring oxygen and nutrients to the nerve cells are damaged. So imagine, if you will, you have the flu, but nobody's bringing you water, nobody's bringing you food. Or if they are, they're doing it once in a while, not nearly as often as you need. So it's much harder for you to heal, and naturally you get sicker. And this double whammy effect on the nerve cell is what causes this neuropathy that we deal with in the heart, stomach, bladder, or on the periphery. So when that happens, it's a perfect setup for peripheral neuropathy, leading to infection, leading to amputation. Let's look at some of those symptoms that we're going to deal with along the way. I tell my patients, we've all been here. You've all sat in the back seat of a car, whether it was as a child or an adult, and you had that foot crossed the wrong way and that foot fell asleep. So you get out of the car, what happens? Foot might be a little bit numb, can barely feel it. As it starts to feel better, it gets painful. It's kind of a spiky tingle. Then it gets tingly, sometimes itchy, and then it's fine. We go through similar things with neuropathy. Patients will describe, and you just kind of got to reverse this process, a tingle sensation, then a burning, stabbing sensation, and eventually it's just a constant pain. Then that pain kind of goes away and it becomes numb. So now you can't feel the foot. You can't tell if you've got a rock in your shoe, and you can imagine the trouble that could cause. You can't tell if your shoes fit well. You can imagine or probably have experienced the trouble that can cause with poor fitting shoes. Your balance is off. Your reflexes are diminished, so your response time is off. Your likelihood of falling, breaking a hip, getting other injuries goes up. So you can see how this neuropathic process can cause all kinds of issues. But the big one is when you get to that numb sensation and you can't feel a cut, and that cut becomes infected. And that's when you enter the world, and I'm sure hopefully you've never, but you've met people or know family members that have gone through it, of dealing with an ulcer. So now you've developed an ulcer on your foot. Maybe it's right in between the fourth toe and the fifth toe, on the top of the foot, or even maybe a little bit on the bottom. A little ulceration, gradually deep. You didn't notice it for a while. Now you see it's got some redness around it, but it doesn't hurt, so you're not worried about it. Keep in mind that would hurt a lot in a patient without neuropathy. And that redness starts to spread. Now it's getting above the ankle, and you're starting to feel it a little bit. Maybe I should get that checked out. So you go see your doctor, and your doctor gets real nervous because they take off your sock and shoe, and whew, it stinks. And maybe there's some drainage there. So they send you into the ER, you get some testing, and we find out, okay, you've got a nasty infection there. You didn't notice it. You didn't feel the pain because of the neuropathy. And that infection, not only has it started to spread in the body, but it's also into the bone. So they send you to the wound care center and the surgeon, and they try everything, and they try to help you heal, but you have high blood glucose. You've been dealing with high blood glucose for quite a while. So your ability to heal is diminished. As a result, you have a sit down with a surgeon who says, we need to take off part of that foot because that infection in the bone is going to spread and get worse. So now you end up with an partial amputation of your foot or a toe. Now, guess what? That's got to heal. Frequently, that has a hard time healing. Things have gotten better, especially at the wound centers, and they can get you through this much easier. But in the old days, it wasn't at all uncommon to spend months going back to the OR because your infection didn't heal and it had to be cleaned out or even more amputated off. So this is pretty scary stuff and pretty nasty stuff if you think about it. The diabetes is responsible for about 60% of all non-traumatic amputations worldwide. So worldwide, toes, feet, fingers coming off, if it wasn't trauma, there's a 60% chance it was diabetes. So we have about a 15 to, 35% ulcer risk, and 85% of all amputations related to diabetes start with an ulcer. So that ulcer is a big thing to watch for. So let's take it from the beginning. Patient has prolonged high blood glucose levels. They heard from the doctor the A1C was 10.5 again. Okay, so that's 6 months. Well, that's better than the 11 it was 9 months ago. Regardless, they have prolonged high glucose levels. So now the feet they were painful for a while, but doc, they feel better now. They don't really bother me because they're numb. And let's say for whatever reason, that patient never got a good foot exam. It went unnoticed. And then they cut their foot. And then that cut, because they can't feel it, they didn't clean it out right away and dress it up with a proper dressing, gets infected. Of course, they can't feel that, so they don't pay much attention to it until the infection has spread. Now they got a little bit of a fever. They notice a red streak coming up their leg. There's some foul-smelling drainage in the sock. So they go into maybe the ER, and they get started on antibiotics and sent to a wound care center. Well, the antibiotics clear the initial infection, but an ulcer develops there because wounds don't heal very well due to the high blood glucose levels. That ulcer doesn't bother me. I can't feel it. But then that ulcer gets infected. And ulcers like to go deep. So if this is the level of the skin, the ulcer likes to act like a pit and go deep in. So now my third infection in this ulcer under my big toe on my right foot is impacting the bone. And now I have to have the conversation with the surgeon about cutting off my big toe. So neuropathy messes up your balance. Having a toe cut off does a hell of a job for your balance. So then I get my toe cut off, and now I have another long healing process. But my sugars are still high, so I don't really feel it. Not that improving the sugars brings all of your sensation back. It can help, but it doesn't bring it all back. And, I'm at risk for infection, so of course that happens a couple more times. And I like that nurse at the ER. I know her by name because I see her often, because I'm constantly going in for foot infections until eventually I've lost the foot. So you can see how this complication can be so nasty for patients. So let's avoid the complication. Let's look at the wound care spot. There's been some advances made in wound care. The medications to treat them are better. There's wound care advances as far as a team approach. They get everybody involved. They get a diabetes educator. Nowadays, I'd like to think, and I hope it's true, in a perfect world, if you had to go to a wound center because you had a sore in your foot and you were a patient with diabetes, I'd like to think that a diabetes educator would get involved, a nutritionist would get involved, your own physician or endocrinologist would be involved, a surgeon would be involved. Everybody's on board day one to help prevent chop, okay? Some of the modern dressings are much better. So you can have physicians, typically general surgeons or podiatrists even, that specialize in wound care. So they've got dressings that create a healing environment. They've got dressings to promote tissue growth. They can grow you a dressing made just for you to keep that wound clean, keep it moist, and keep it healing. They can use a negative pressure dressing, like a little vacuum there that creates a negative pressure to help draw the infection out, but also to draw blood flow and improve the blood flow in that area to promote healing. There's the hyperbaric chambers, where it's like you're diving in the ocean. You're in a tubular container where you're breathing 100% oxygen, and the wound doesn't like that. It prefers carbon dioxide. So the wound tissue dies, and then they take you and clean off the dead tissue and repeat the whole process to help you heal. So the advances that have been made in the treatment of foot wounds, or any wound for that matter, in patients with diabetes are great. And at the same time, there's been some tremendous advances in controlling our diabetes. But the key is up here for us to make sure those glucose levels aren't up forever, and work hard with our provider, our diabetes educators, our endocrinologists, whoever, to get those blood sugars down. So prevention, obviously I just alluded to it, tight glucose control. The diabetes control and complication trial back in the 90s was stopped due to compassion. And it was stopped because what they had learned is by following kids with diabetes, and one group was control, one group was what they called intense control, which is nothing compared to what we do now. But when they found the group of the intense control was lowering their rate of diabetes complications significantly. And it was considered poor form to continue this trial without sharing this information as soon as humanly possible. So this trial really proved tighter control reduces complication rate. And that goes for neuropathy as well. Daily foot checks. They make all kinds of mirrors, and most of your drugstores will carry them where you can check the bottom of your foot really easily. If you're not flexible, I have that issue. Involve your spouse, your loved ones. Have them tickle you. Do you feel it? Good. Do you notice the rock in your shoe? I used to tell a friend, we were hiking, like, oh, I got a rock in my shoe. And they're like, oh my gosh. Like, no, this is great because I feel it. I know it's there and I'm going to fix it right now. Daily foot checks. Look for injuries, look for cuts, look for beginnings of ulcerations. Make sure the foot is warm. Make sure you're wearing the proper footwear. Proper shoes, hiking shoes when hiking. Avoid barefoot outdoors across the gravel and into the mud. Common hygiene things that we don't often think about, but are real important to keep those feet and extremities healthy. And I think probably the best one is getting involved with a podiatrist, especially for elderly folks. Get their nails done, get it checked out, make sure their feet are in good shape, but also to act very early. If you see a little red mark, don't sit and wait. And I've seen this in the ER numerous times. A patient comes in and they're going up to the ICU with a major infection in their foot. Flash forward a year, last time it was really bad, so we wanted to come in quickly. And they come in with a little tiny dot of redness that I'm not even sure what to do. It's so early. But that's the aggressive type of foot care you want to have. And if you have a podiatrist that you can see or work within your area, that's wonderful. Great specialization, so useful for patients with diabetes. So that's the nuts and bolts of diabetic neuropathy, both peripheral and autonomic. It's a nasty complication that we all hope to avoid. I would give you a hint at next week, but too often I fib about those. My guess is we'll probably continue with some of the other complications. They are dark and scary, and nobody likes to think about them, but it is essential to know thy enemy and know how to avoid it. So please give us a like, a comment, share your ideas. If you want to see more diabetes videos, if you want to see more about living with diabetes, winning with diabetes, give us a subscribe. And most importantly, like I always say, stay healthy.